Most people call them ear, nose, and throat doctors. The board exam calls them head and neck surgeons. The senior version of this job is removing the parts of a person that produce their voice, the tongue, the jaw, the larynx, and rebuilding what is left out of a piece of their own forearm. You will see your first total laryngectomy on a Tuesday in March. The patient is 58. He sings tenor in his church choir. His wife and his grown daughter are in the waiting room. He will not sound the same on Thursday. One day that surgeon is you. Level 1, the intern. $68,000 a year before tax, 80-hour cap weeks. Half your year is not really ENT, 6 months of general surgery, intensive care, and anesthesia before you touch a head and neck case. Most mornings, you pre-round on belly wall infections and central lines. The headlight your grandmother bought you for graduation sits in its box on the apartment shelf. 2 a.m. in November, the pager goes off. Parotid abscess on the 7th floor, the airway is starting to swell shut. The ENT senior is running the consult. You walk the patient down to the OR and gown up next to her. You hold a retractor for 65 minutes while she drains the abscess and traces the facial nerve. You do not put a finger on anything important. The case ends at 4:20 a.m. You round at 6. 2 days later in clinic, the patient asks the senior who you are. The senior says you helped take care of her in the middle of the night. The patient looks at you and says thank you. You have not slept 12 hours total that week. You matched into one of the 4 most competitive specialties in the country. In 2024, ENT filled 96% of its positions with American medical graduates. You cannot say any of this to anyone without sounding insufferable. Your family still cannot tell ENT from optometry. $212,000 of medical school debt is now in repayment at 6% interest. 18 months from now, that headlight is on your forehead at 11 p.m. in a trauma bay. The hole in the neck is yours to make. The headlight stays in the box another 6 months. Level 2, the junior resident. $75,000 a year, 60-hour weeks on a good month, 80 on most. The headlight comes out of the box in July. You wear it at every consult. You wear it at every clinic. 2 months in, you walk to the bathroom and realize it is still on your forehead. 11 p.m. on a Tuesday in February, the senior pages you to the emergency department. A 56-year-old woman with an obstructing supraglottic tumor. Anesthesia cannot get a tube past the mass. Oxygen saturation is in the high 70s and dropping. You are already gowned by the time she rolls into Trauma Bay 6. The fellow is on the highway. He picks up the phone while he drives. You feel the cricothyroid membrane with your gloved finger. His voice on the speaker tells you when to cut. You make the incision. He says, "Good. Now spread." Your hands do not shake. The track is in by 11:18 p.m. The saturation climbs to 98. Median ENT chief residents graduate with 1 to 2 emergency surgical airways across all 5 years of training. 18% finish with 0. This one is yours on a Tuesday at 11 p.m., 2.5 years before you are even a chief. The next morning, her family is in her room. They want to know when she will speak again. The trach is temporary. Once the tumor is debulked next week, the larynx will be reopened and her own voice returns. The family does not relax until they hear that twice. 3 weeks later in clinic, she leans into the speaking valve attachment and tells her sister on the phone that she's going home Friday. Her own voice. Between calls, the daytime cases are bread and butter. Tonsillectomies on 6-year-olds. Ear tubes on toddlers with chronic infections. Endoscopic sinus surgery on the patient who has not breathed through her nose since 2020. Septoplasties on the rugby player who broke his nose in 3 different countries. 2-hour cases. Home for dinner with your roommate 3 nights a week on the weeks the pager is quiet. The first track you place is the first time someone loses her voice because of you. You saved her life 10 minutes earlier. You carry both facts the same way you carry the headlight, somewhere on you all the time. 2 more years before the case mix is yours to run. Level 3, the senior resident. $82,000 a year, 2.5 years of headlights, scopes, tracks, and 25-hour weekend calls behind you. The case mix opens up. Adult thyroids and sinuses, tonsils that won't quit, parotid masses, neck masses, sleep apnea patients who have been told for a decade to stop snoring. Your first septorhinoplasty, your first thyroidectomy, your first selective neck dissection. Under the attending's hands, then under her eyes, then alone. First parotidectomy as primary surgeon. The patient is a 41-year-old graphic designer with a lump under her right ear that has been there for 8 months. You stage it as a benign pleomorphic adenoma, the most common parotid tumor, and counsel her on facial nerve risk in the pre-op visit. She signs the consent. She asks twice whether she will lose her smile. The attending tells her 95% of these cases recover full nerve function within 3 months. The case takes 4 hours. The facial nerve runs through the parotid gland in 5 branches. You identify the main trunk, dissect along it, lift the tumor off the lower branches with a fine clamp. The attending stands across the table and watches. Once she nods, you keep going. 3 weeks after surgery, the patient comes back to clinic. The right corner of her mouth is half a centimeter lower than the left. She tries to smile, and one side of her face does not answer. The tumor was benign. The nerve was preserved anatomically. The recovery will probably take 3 months. Probably. Temporary facial nerve weakness occurs in anywhere from 9 to 65% of parotidectomies depending on tumor size and approach. Permanent paralysis runs 0 to 8%. The word probably becomes the hidden cost of every surgery you do from this year forward. The benign cases are the ones that wreck you. The patient did not have cancer, and she still does not look like herself in the wedding photo 3 weeks later. After clinic, your attending follows you into the workroom and closes the door. She will recover, he says. Most of them do. You stand there a minute. The window faces the parking lot. You count 6 cars whose owners are probably also having a bad week. The next parotidectomy goes clean. 3 months out, that patient walks into clinic and gives you a full, even smile. She brings a photo from her sister's wedding the Saturday before. 5 years from now, you are the one telling a 3rd-grade teacher she will lose her tongue. The white patch starts at her September cleaning. Level 4. The chief resident. $88,000 a year. Board eligibility comes this June. Tumor board is at 7 a.m. every Wednesday morning in a windowless conference room on the 8th floor. 3 head and neck surgeons, medical oncology, radiation oncology, pathology, radiology, dental, speech-language pathology, social work. 3 nurse navigators with stacks of charts in front of them. Your job is to present 9 new cases this week. You pull up the imaging, summarize the history, read the path report aloud. Tumor board changes management in roughly 1 in 5 head and neck cases. Today, case 6 is yours to take back to clinic. She is 47, elementary school teacher, 3rd grade, 16 years at the same school. Tongue cancer found by her dentist at a cleaning in October, a small white patch she had been chewing around for 4 months. Biopsy came back T4. The tumor crosses the midline of the tongue and invades the floor of the mouth. The recommendation from tumor board is total glossectomy with free flap reconstruction, followed by chemoradiation. She walks into clinic Thursday morning at 10:15 a.m. with her 17-year-old daughter. Your attending stands beside you. You do most of the talking. Your headlight is off on the desk between you. You explain what total glossectomy means. The entire tongue is removed. The free flap, you tell her, is tissue and skin from her forearm, sewn under a microscope into the mouth to fill the space. Her speech will be different. Her swallow will be different. A speech-language pathologist will work with her for the year after surgery. She does not cry. Her daughter does. She asks one question: how long after surgery before she can read aloud to a classroom? Your attending says the speech pathologist will know better. You say 6 to 9 months for clear speech, longer for projection. She nods once and signs the consent. The week before her surgery, an essay arrives in your inbox from her daughter. The subject is her mother's voice. 15 years of reading aloud at bedtime. The daughter is sending it as her college application essay and wants you to know what the surgeon will be working on. 6 years ago, you did not know what a glossectomy was. 6 years ago, you were standing in your dean's office trying to convince him to write your ENT recommendation letter. Match week for fellowship is in 3 weeks. You match into head and neck oncology. Level 5, the fellow. $95,000 a year. 2 years of fellowship in head and neck oncology and microvascular reconstruction. Match week 3 years ago, your class split 4 ways. Your friend from intern year went to facial plastics. He does 4 rhinoplasties a day for paying clients out of a clinic in the Flatiron, home by 5. Your old call partner went to PEDs. She has 200 tonsillectomies and ear tubes into the year, home for dinner with her toddler. The one you envy most went to neurotology. She drills millimeters from the facial nerve to place a cochlear implant in a deaf 2-year-old. At the activation visit, the child hears her mother's voice for the first time. A third of your class skipped fellowship entirely. They are already attendings, banking $400,000 a year while you bank $95,000. You pick the year with the longest hours and the lowest hourly rate. First free flap, raised solo. Radial forearm, thin, vascularized, the gold standard reconstruction for tongue defects. You harvest a strip of skin and underlying tissue from the patient's non-dominant forearm, with the radial artery and a vein still attached. The arm is closed with a skin graft. The flap goes upstairs into the oral cavity defect. The microvascular anastomosis is the marquee skill of the year. Your headlight is off. The operating microscope is the only light source for the next 2 hours. The patient's neck vessels are exposed below the angle of the jaw. A recipient artery and a recipient vein, each about 1.5 millimeters in diameter. The radial pedicle comes into the field next. You sew artery to artery first. 9/0 nylon, 8 to 12 interrupted stitches. Then you sew vein to vein. The clamps come off. The attending watches the field for blood flow. The flap pinks up inside 30 seconds. The room exhales. Day 3, the patient is sitting up in the intensive care unit. The flap is pink and warm. Doppler 4+. The speech therapist starts tomorrow. A different patient, 2 weeks later. The intensive care unit calls at 3 a.m. The flap looks dusky on the bedside check. Doppler is silent over the anastomosis. You walk back in. The patient is intubated, sedated, family at home. You take her back to the OR by 3:50 a.m. The vein has thrombosed. You revise the anastomosis under the microscope. Sometimes the flap comes back, sometimes it does not. Free flap failure rates in modern series sit between 7 and 12%. When the flap fails, the bed has to be debrided. Another flap is raised, pectoralis major from the chest often, or a regional flap from the neck. The patient who was supposed to have a tongue made from her own forearm wakes up to a chest flap and a feeding tube. The wedding you miss in April is your cousin's. The funeral you miss in July is your residency, program director's father's. The last vacation you took was 7 years ago, after step 1. The PD's fellow is at her toddler's preschool concert tonight. You knew. You picked this anyway. In November, you sit for the Otolaryngology board exam. 4-hour-long oral sessions, 3 examiners each. You pass. The first laryngectomy of your attending career is on the schedule for late spring. Level 6, the junior attending. $450,000 a year. Your name is on the door this morning. First total laryngectomy as the surgeon of record. The patient is 58. He drives an HVAC truck. He sings tenor in the choir at St. Stephen's on Sunday mornings. He has a glottic squamous cell carcinoma that grew through 3 years of radiation and a partial laryngectomy. The tumor now occupies the entire larynx. Tumor board's recommendation is total laryngectomy. The pre-op conversation takes 70 minutes. You explain what a total laryngectomy removes. The entire larynx is taken out. A permanent stoma is created at the base of the neck, a hole through the front of the throat that connects directly to the trachea. Air will move in and out of that stoma for the rest of his life. He will never breathe through his nose or mouth again. The natural voice is gone forever. Then you explain the three options for speech after surgery. A tracheoesophageal puncture with a Provox prosthesis is the most natural laryngeal voice. The prosthesis is a one-way silicone valve the size of a pencil eraser. Exhaled air shunts from the trachea into the upper esophagus and vibrates the pharyngoesophageal segment. He occludes the stoma with his thumb, exhales, and the upper esophagus vibrates instead of his vocal cords. Roughly 75% of patients who get a Provox report improved quality of life. About 50% of laryngectomy patients develop clinical depression or anxiety in the year after surgery. You explain both numbers. Then you describe esophageal speech and the electrolarynx. He listens. He asks two questions about the Provox. He signs the consent. The surgery takes 7 hours. The headlight is on the entire time. The reconstruction is straightforward. The Provox goes in at week 3. 6 months later, he calls his granddaughter from his kitchen with the prosthesis. He occludes the stoma with his thumb. He says her name into the phone. She picks up the line and says, "Grandpa." He tells you at the next visit that it was worth it. He is in the 75%. The next morning, you start a folder on your desktop labeled Calls. The first thing in it is the photo of the tenor's granddaughter. 11 years of phone calls are ahead of you every 6 months from the same kitchen. Level 7, the mid-career attending. $600,000 a year, 17 years past fellowship. Your name is engraved on the Head and Neck Oncology Fellowship plaque on the 3rd floor wall. The headlight is on the desk most weeks now. You operate on Mondays and Wednesdays only. The patient is 42. He runs the warehouse for a regional grocery chain. He has 3 kids in elementary school. He has never smoked. His wife called the lump on his neck a weird bump. The biopsy came back as recurrent HPV-positive oropharyngeal cancer, 6 months after his second round of chemoradiation. 70% of new oropharyngeal cancers in the United States are now HPV-mediated. 5-year disease-free survival in HPV-positive disease is above 80%. The patients are younger, mostly male, mostly white, mostly non-smokers. You will probably cure him. The decision in clinic on Wednesday is the operation. Transoral robotic surgery, which is approved and recommended for selected recurrent HPV-positive disease, or open lateral pharyngotomy with free flap reconstruction. Your partner says TORS, you say open. The neck is radiated, vessels are scarred, you want direct access. Tumor board splits down the middle. You take the case. The surgery goes well. The flap survives. Pathology returns clean margins. 3 months out, he is back at the warehouse part-time. He brings you a box of pears from his neighbor's tree at the post-op visit. 6 months later in clinic, his wife asks if she can speak to you alone. She tells you she has not slept through a night since the recurrence. Her hands shake during the conversation. She has lost 12 pounds. Their teenage son stopped eating dinner with the family 3 weeks after surgery because the swallow does not come back the same. She asks if there is a number she can call when the panic comes back at 3 a.m. Fear of cancer recurrence scores are highest in the youngest patients. About a quarter of head and neck cancer patients are feeding tube dependent at 12 months. You start hearing the same story at head and neck oncology meetings, same age range, same kids in school, same wife coming back alone for the next visit. Your mentor stopped doing tours at 52. At his retirement dinner, he said the cures had started to feel like a deal he never made. On the Wednesdays, the wives ask to speak with you alone. His sentence comes back. Wednesdays are also when the old patients call your line. A Wednesday afternoon. You are in your office between cases when the front desk forwards a call to your direct line. It is the tenor, 11 years now since the surgery. His Provox is loose. The prosthesis lasts 3 to 6 months on average, and his is overdue. He calls every 6 months from his kitchen. The voice on the other end is not his old voice. He occludes the stoma with his thumb. Exhaled air shunts through the prosthesis, into the back of his throat. The result is a low mechanical voice that sounds nothing like the tenor who sang at St. Stephen's. He uses it to tell you his granddaughter started kindergarten last week. You hang up the phone. The headlight is in your desk drawer. The folder on your desktop labeled Calls has 11 years of photos in it now. The tenor's granddaughter, the teacher's daughter holding her diploma, the warehouse manager's youngest son at Little League. 1 p.m. Your next case is on the schedule.